everyone. Today we will be talking about the knee chest and how to apply some corrections for the sacrum, the lumbars, thoracics, and the cervicals. So first we will start by explaining how to get the patient properly on and off the knee chest. So we first start here at the base of the table, and then if the patient has a bad knee, then you will tell the patient to first put that bad knee on the cushion support here, and then stay on with the good knee. So I'm assuming this is my bad knee, so this is my first one. I'm staying up with my good knee, then I'm gonna put it down. As I am approaching to the knee piece, I would put my hands as for support. Then finding out these handles on this area, I would grab them and slide my chest up into the hole. I'm sliding my chest up into the hole. So it would be grabbing the handles, sliding, and getting in. And while I'm going off of the table, we will be doing the same process but in reverse. From the handles, approach the chest support, then bring up the good knee, and then lastly the bad knee. Keeping the spine as straight as possible.
Okay, so now we're going to talk about how important the knee chest is, because you can literally adjust from occiput down to sacrum. So today we're going to discuss those important aspects of adjusting them on the knee chest. We're going to start with the occiput and then work our way down. But one thing I want to make sure is I already have Kate on the table. I made sure her knees were where I want her. I put the leaves where her spine is most relaxed throughout the entire spine, and where she's most comfortable. So I already have her in perfect patient placement. Okay, so we're gonna start with the occiput, and what we're gonna do is we're gonna have the patient down, and we're gonna have the patient turn their head and look at us. So the patient would turn their head and look at us, and we'd be contacting the mastoid just like we would if we were doing it in the chair. So the occiput has gone posterior, superior, so we're gonna shade a little bit superior to the patient, and we're going to be contacting the mastoid with our superior hand, and we would just be contacting, and we'd want to go down in that joint. And then if it was PS, LS, LP, then we would want to get over the patient a little bit so we could kind of get that torque into us. If it was PS, LS, LA, we'd want to be a little bit further away so we can get down and away from us. And then from here, we would also have the head turned for the atlas. So for the atlas, if we were doing AS, we're contacting here, the head's turned towards us, and we'd be contacting on the transverse process of the atlas, and with our superior hand again, and we would, okay, so we'd get in there, and it's the same thing. If it's AS, LP, we want to be closer over the patient so we can get that torque, and we're torquing down. And if it's LA, ASLA, we'd want to be further away so we can torque away. Then if it's AI, we'd want to make sure that we're torquing up because of where the misalignment has gone, which we've talked about previously. And then the same thing for the LA, AI, LA, AI, LP. All right, so something that's important for the upper cervical is we can kind of see while palpating this area up here if the patient is more relaxed if we bring her arm up and have her relax it up here on the headpiece. And while you do that, you're going to be palpating this and see if it relaxes. If it does relax, then I'm going to, throughout the adjustment, I'm going to keep her arm up. If she feels more relaxed when I bring her arm back down here, then I'll keep her arm down. But that's definitely something we need to check for patient comfort and to make sure that the adjustment goes as smoothly as possible and having her in the most relaxed situation. So I actually think I'm going to keep your arm up here, okay? And for the occiput, we're going to find that mastoid. We're going to come in with our superior hand here. I'm going to be favoring the superior part of the table. And then I'm going to feed in and then go down. And it's a set and hold. I'm not recoiling at all on her. And if it was a PS, LS, LP, as mentioned before, I'd get in here and I would want to come down and towards me. If it was PS, LS, LA, I'd be a little bit further away. So I can come in and I'm going to go down but away. And then for the atlas, again, I would have checked for her arm. And then I'm going to go palpate in here. I'm going to slide off that mastoid onto her TP. So this is for an for an ASLP. I would get over top of the patient here. And I would want to go down and torque down as well. ASLA, further away. Get onto that transverse, torque down. For an AILP, I'd come over, tissue pull, and now I'm going to be torquing the other direction. And it's just so important to make sure we know that this is a set and hold. We do not want to recoil on these. It's a very gentle adjustment. So it's just a squeeze down, a quick little thrust, and hold it there. Okay, so now we're going to show you the cervicals from C2 to C7. There's a couple different hand placements you can use for this, so we're going to go over each one. So I'm going to show you a PL double thumb, and what that would look like is if I had really bad hitchhiker thumbs and my thumbs like bent back, I'd probably come on this posterior inferior aspect of the spinous here and tissue pull up, and I would kind of keep my thumbs like this just because my thumbs are going to bend back. But since I don't have the hitchhiker thumb, what's more comfortable for the patient is tissue pulling up to that, reinforcing and keeping my hands here, and then it's a lift and set. I would do that up the entire spine wherever I found the listing. This is important to know the displane line of each one of these vertebrae as you go up the spine, to know how much you need to lift and set, or if you need to just lift and go down, lift and arc back. It's very important to know the displane line while doing this, and not of just any spine, but of that patient's x-rays. So you would obviously have those up in your office somewhere when adjusting them. Now, if I had a PRI and I need to contact the lamina for a double thumb, I'm going to tissue pull up here, and I'm going to stabilize on this right side here. And I'm going to be here, and then it's going to be, I'm going to lift, and I'm going to set, but I'm only applying like 20% pressure on my right thumb on this side, and more like 80% pressure on my left thumb. And again, that can be applied all the way up from C7 to C2. Another way you can do it is your pisiform. So if I was doing a PLS again, I would come here, get my tissue pull and come across on my pisiform on that inferior aspect of that spinous and lift and set. Or you can do a knife edge if you really just need to get that lift and posteriority out. And I would come up on that patient with a knife edge, and I'm literally gonna lift and set down with the knife edge. I'm gonna now show you on the patient all of these. Again, just like anything with the knee chest, this is a set and hold. Okay, so now I'm going to show you on the patient, and just like the cervical chair, we have a handy dandy strap here to make sure the head doesn't pop up when we're adjusting any part of the spine and create a whiplash effect. So one thing to make sure when you're putting the strap on, you don't want to pull it on and then have a lot of rotation in the head. So just make sure maybe you can have the patient's head turned a little bit. So when you apply the strap and pull down, you can have the head angled, and by the time you get ready to put it in, their head is completely neutral. So now that I have the strap on, I'm just going to show you everything on C7, but these can apply from C2 down to C7 here. So we did double thumb, a PL. So I would find that spinous. I'm going to tissue pull to it, torque this one in, and I'm on the inferior aspect, reinforce with this one, and then I'm going to lift and set, lift and set. And then if she had a PRI-L, I'm going to be right next to that spinous, and I'm going to go right onto that lamina here. My right hand is my stabilization hand, and then my left one is my contact point. So I'm going to lift 80% with my left thumb here, lift and set, and my right thumb is only going like 20% just to help stabilize. If I was to do a pisiform for the C7 here and I had a PL, I would torque it in just like we would for the thoracics, and I'm going to make sure that I lift and set down. And then now we can do that knife edge. So you're going to find that bottom of her spinous here, come up into it, and I'm going to lift and set down with that knife edge. So now we're going to explain the hand placements for the lumbars. So for the lumbars, we have a couple more. We can do that double thumb, just like we would for the cervicals. So I'll do a PL here at L2, and I would tissue pull up to the inferior aspect of the spinous, get reinforced, and I would come up, up and down. And then we have the same thing, where it's PRI-M. I would be here and here. And then we have that 80-20 and set down. For L1, we can do double thenar. So we're standing nice and close to that spinous, we're going to get our thenars here and we're going to lift and set down. We can do pisiform contact, where we're going to be tissue pulling up, get on that inferior aspect of that spinous and set down. If we had a PRI and we're contacting that mammillary and we're going to stay on the same side of the spine, we're not going to cross. We can do a thumb and then pisi over thumb. So we would tissue pull up here, have that come and nice and relax, and then set and hold. And we can do this from L1 to L5. Double thenar, probably only at like L1. And then the main thing that we need to remember with the lumbars here are these displane lines. With that lordotic curve, we really need to make sure we're taking note of this displane line versus L5 and L1. They're completely different. And depending on that patient's lordotic curve, it will change tremendously. So that is something we really need to keep in mind when we're setting, so we're not just jamming that patient's spine in. So now I'm going to show you on the patient what these would look like. And one key thing to remember with the patient is we need to make sure that patient is nice and relaxed and that we have what we're adjusting at the right level. So we want to make sure that she's nice and relaxed here. Everything is nice and relaxed. And you really want to make sure you feed in on the patient here, because with that lordotic curve, they can keep going. And I would not want to just thrust from here because it's going to be a long, probably painful thrust. So let's show you that double thenar first at L1. Just because you're really only going to do that at like L1. So that double thenar at L1 for a PL or PR-I, you would come here like this. I'm going to have my pressure. My whole hand is contacting the patient. My hands are nice and relaxed, but my pressure is only here in my thenar pad. So you want those thenars nice and close. I'm like pinching that spinous, but I'm contacting mainly on that mammillary there. And I'm going to lift and set up there. And again, it's going to be mainly pressure on my left hand if I'm doing a PRI, and not as much on my right. So now we can show you that double thumb. We'll do that at, say, L3. So for that double thumb, we'll do a PL first. I'm going to tissue pull up, get this one in, reinforce with my right, and I'm going to lift up and set. And then if I had a PRI, I would come off this one over here. And I'm going to do 20% with my right, 80% with my left, set up and down. And set and hold. So now I'm going to do that pisiform at L5. And for that pisiform at L5, what I can do is, so that way I can help stabilize the patient, I'm going to do a PR. So now I'm going to contact this part of the spinous here, and I am going to, so now I'm going to show you the pisiform, and I'm at L5. And for the L5, you can reach across. So I'm going to do the PLI over here on this mammillary, and I'm going to contact with my inferior hand here. And remember, the wedge is over here now. So I'm going to come here. This will help because I'm stabilizing the patient here with my body. So when I go thrust, I'm like closing that wedge and that patient's not going anywhere. Instead of being on the same side, it's just kind of awkward trying to close that wedge this way. It's just a lot more comfortable if I'm over here and I have this patient nice and controlled and I'm going to like that. And now the last one that we mainly talk about doing is a thumb, or thenar over thumb, or pisiform over thumb. So I'll just go ahead and show that at L2. So just pull up here, set my thumb in nicely, and then I'll do thenar over thumb. So my thumb here is going to just be nice and relaxed. I'm not digging in with my thumb here. That'd be really uncomfortable. My thumb's just relaxed, and I'm going to feed in with my thenar and set and hold down. All right, so now I'm going to show you what to do for a sacrum. So for a sacrum, we can do individual tubercles, and we're going to be setting the one below to the one above. So you can do, for a more specific context, you can do thumb over thenar or pisi again, and you're going to be setting it mainly P to A, but you're also lifting it and setting it up to that one above. You can do a whole rotated sacrum, and that's where you're going to be contacting here, and you're going to get over that patient and kind of thrusting back down towards you and P to A. You can do pisiform for a tubercle, and you mainly want to use your inferior hand just because of patient comfort. So you're going to come up to that tubercle, get your pisiform on it, and then you're going to be lifting P to A and setting, again, the one below to the one above. I'm going to show you. You can do a base posterior, so you can set your pisi at like S2. You don't want to influence S5 at all. You'll make it worse. And you're going to come in, and you're going to go in an arcing motion and set that sacrum down and in. So let me show you on a patient. So for a patient, we're going to find which tubercle is painful or which tubercle needs to be adjusted. So we'll do S3 here, and I'm going to show you the thumb. So I'm going to come in with my thumb here, come in with my thenar, and I'm going to stay relaxed. I'm going to feed in and P to A. Set and hold that sacrum down for her. And then pisiform for that S3. Here. Stay nice and relaxed. Feed it in. Set and hold. Rotated sacrum. So we're going to contact that S2. The inferior hand here. And we're going to get over so we can make sure we're going to send that sacrum down so it's not posterior on the left side anymore. And set and hold. Base posterior. So contact S2. We don't want to influence S5 at all. So come here. And we're just going to set this in an arcing motion. P to A. Okay, so we just got done showing you how you can adjust the occiput all the way down to the sacrum, and you can even adjust the coccyx on this table. This table should be an extremely light, comfortable adjustment because it is a set and hold, not a recoil. You're following the patient's breath. You're utilizing the discipline line, and this should not be an uncomfortable adjustment for the patient. Now, all the segments that we showed today, this is a secondary option for those segments. You want to adjust the cervicals in the cervical chair and the lumbars and sacrum on the pelvic bench. But if the patient, for whatever reason, cannot handle being set up on the pelvic bench or in the cervical chair, this is a great secondary option. Or if the patient has a lot of posteriority, then this is a great option for them. Or if they need help with extension, then this is a great option. It's just kind of patient by patient basis for using this table, but those are the primary adjustments for the lumbars, the pelvic bench, and cervical chair for the cervicals.
Thank you for watching today's video. So as you know, we covered everything that we can possibly do on the knee chest. So please follow us on Facebook and on Instagram, and just find out the study sheets on there because it's going to be posted. So thank you.
Thank you.